All right, today we're going to talk about the endocrine system. And so we're going to try and do this with as few interruptions as possible today. You will have access to these in your account that you're able to print out these notes. I did use a slightly larger font just for being able to present them on the screen here a little bit easier, but if you're looking to shorten it up a little bit when you're printing it out, you can shrink the font down. It's a 14-point font right now, and it will minimize how much printing you have to do if you shrink the font down. So here is a picture of our endocrine organs here. You can see that they are slightly different in the male and the female based on the reproductive organs, but otherwise the upper portion are the same. The endocrine system is largely for regulation. What it's aiming to do is maintain homeostasis in the body, which is where we try and keep a consistent environment. So all living organisms need to do this, and the failure of this is actually what is behind a lot of diseases. So the endocrine's job is to do communication in this homeostatic feedback loop system. Endocrinology is the study of the endocrine system. So the endocrine system does work together with the nervous system. Both of them are going to be for communication. With the nervous system, it's going to do this with nerve impulses and neurotransmitters. It's faster, but the effects are also going to be briefer, and it can act on a specific target. So if there is something that's life-threatening, you want a nervous system response. That's going to give you that message right away. So it's great for short-term crises, gives direct communication with an electric impulse. With the endocrine system, hormones are going to be used. They act as a mediator molecule. They're produced in one part and then regulate something in another part of the body. The response is slower, but it does last longer, and it tends to have a broader influence. So it can regulate more long-term processes, like metabolic changes, and it uses chemicals for communication. So for something like going through puberty, you really wouldn't want that to be as quick as the nervous system could handle it. It's better that the endocrine system handles that, more of a long-term gradual change. So this is showing here in this picture, you've got an example of a nerve sending an impulse for communication. Here's an example of an endocrine gland releasing a chemical into the bloodstream that's going to be used for communication. So we'll shrink this back down here. So we have two kinds of glands in the body. You have endocrine and exocrine glands. The exocrine glands have a duct, so they're going to put their secretion in a duct, and it's going to drop off their secretion where it needs to act. The endocrine glands are ductless. They will secrete their products into the interstitial fluid, and then it can diffuse into the bloodstream, and they end up carrying out their function elsewhere in the body. So your endocrine glands include things like the pituitary, the thyroid, parathyroid, adrenals, pineal glands, also the hypothalamus, thymus, pancreas, ovaries, testes, kidneys, stomach, liver, small intestine, skin, heart, adipose tissue, and placenta. They have endocrine tissue in there, but they are not exclusively endocrine glands. So when we look at the three types of glands, pure endocrine glands would include things like the thyroid, parathyroid, adrenal cortex, thymus, and pineal gland. There are some glands that are both endocrine and exocrine. This would be the pancreas, the ovaries, and the testes. So they've got both types of glands in there. And then the neuroendocrine glands would include the adrenal medulla, the hypothalamus, the supraoptic nuclei and the paraventricular nuclei that are posterior pituitary. So they can have actions that come from both the nervous system and the endocrine system. Again, this picture here, this just gives an overview of different endocrine glands in the body. So you can see hormones that are going to come from each of these glands. So if you're looking for a picture that kind of summarizes things, this is a nice picture that you would definitely consider using. So when we look at the hormone activity, hormones are going to affect only specific target tissues with specific receptors in there. They don't end up in unplanned places. The receptors are going to be constantly synthesized and broken down. So you'll have a range of 2,000 to 100,000 receptors on the target cell. This allows their response and activity to be regulated. So if one is downregulated, this could happen from excess hormone, it will produce a decrease in the number of receptors. The receptors would just undergo endocytosis and be degraded. And then the cell is going to have decreased sensitivity to the hormone. When something is upregulated, this would happen if there's a deficiency of the hormone. It's going to produce an increase in the number of receptors. That's going to end up with the target tissue being more sensitive to the hormone. So what's going to stimulate the hormone may be hormonal or humoral. So if it's hormonal, it can be things like the pituitary gland sending tropic hormones to another gland. If it's humoral, it can be things like fluid or ion levels that can send signals. An example would be the blood glucose levels. And then you can have neural stimulation, such as stress that would come through the nervous system. Then the hormones are going to be removed from the system. This is usually done by the liver or the target organ itself, and it will break it down to be eliminated, and it's usually going to be eliminated through the kidney. So with hormones, some of them can be circulating. Well, those circulate in the bloodstream throughout the body. Others will act more locally. So when it's paracrine, it's going to act on neighboring cells. When it's autocrine, it will act on the same cell that actually secreted it. But both of those do act in a local space. With the endocrine, they can travel to other locations. So when we look at some examples, they may be lipid soluble or water soluble. So lipid soluble, these would use transport proteins. These would be things like steroid hormones, thyroid hormones, and nitric oxide. Where water soluble, these can circulate in their free form. So this would be things like the amines, peptide or proteins, eicosanoids, and glycoproteins. So this image here is just going to give you an example here where you can have an endocrine cell. It's going to release the hormones into the circulation. They can take it to the distant target cells. Here you can have local hormones. So you've got a paracrine cell releasing to a neighboring cell. Here in autocrine, it's going to release the hormone and then work on itself. So steroid hormones are going to be lipids that are derived from cholesterol. And they will have different functional groups attached to the core structure, but the sterol molecule in the cholesterol is going to be their main part of their structure and also accounts for a lot of their properties and how they're transported. The thyroid hormones, these have a tyrosine ring on them, and then they're going to have iodines attached that are lipid soluble. And then nitric oxide is actually a gas, and we find that in blood vessels. So the amine, peptide, and protein hormones, they're made from modified amino acids or amino acids that are put together. Some examples include serotonin, melatonin, histamine, epinephrine, and some of the glycoproteins. Catecholamines, these are monoamine neurotransmitters. They're called that because they've got a catechol ring in there and an amine on them. And they can act as a neurotransmitter and as an adrenal hormone, depending on their location. So it's a neurotransmitter when it's communicating between nerves. The hormones will act on other tissues. And the eicosanoids, these are derived from arachidonic acid. It's a fatty acid that you get very easily in your diet. These would also include the prostaglandins or leukotrienes. So the prohormones, these are precursors to the hormones themselves. They generally have limited, if any, activity. So the mechanisms of action in general, the response will depend on what the hormone is and what the target cell is. So lipid-soluble hormones bind to receptors inside of target cells, where with water-soluble hormones, they'll bind to receptors on the plasma membrane. This will generally activate the second messenger system, and it allows for amplification of the original small signal. The responsiveness of the target cell is going to depend on the concentration of the hormone, how many receptors you have, and then this can also be influenced by other hormones. So the effects may be permissive, where they allow something to happen, synergistic when they work with something, or antagonistic where they're going to oppose something. So they can end up having effects directly on genes. So in this diagram here, you can see you've got the steroid hormone. It's going to come in and attach to the receptor. So the receptor could be in the cytoplasm or in the nucleus. Here, if it's in the nucleus, it is able to influence regulation of the DNA here. It can bind to the DNA, activate the gene, start transcription and translation, and then lead to the target cell for the response. So here, an example with thyroid hormone, it can also do this, where it will either bind to something in the mitochondria or to the receptor and bind to the DNA and then activate the gene. So here, when it's in the mitochondria, it will increase ATP production that will influence the target cell's response. So this here is going to show more of your second messenger system here. So you can have it affect the cyclic AMP levels here. So the hormone would come in, attach to the receptor. It's going to activate the G protein. You'll have activation of the adenylate cyclase, and this cyclic AMP acts as a second messenger to trigger the response. Some examples of this would be opening ion channels or activating enzymes with epinephrine and norepinephrine, calcitonin, parathyroid, ADH, ACTH, FSH, LH, TSH, or glucagon. So then you can have the inhibition of the adenylate cyclase in here, and then you'll have more breakdown of the cyclic AMP, and the phosphodiesterase is going to do that. So this is going to lead to enzyme inhibition. Here's an example with it affecting calcium levels. So you would have the hormone come in, the G protein is activated in here. It's going to activate the phospholipase C and will trigger the release of stored calcium. And then the calcium will end up having other effects like opening calcium channels, calmodulin leading to enzyme activities, and acting as a second messenger system. So when you have the amplification, what happens is a single molecule of the hormone will bind to the receptor, and then it can activate hundreds of G proteins. So each of those will activate an adenylate cyclase, and that can produce 1,000 cyclic AMP, the phosphodiesterase, and enhanced breakdown of the cyclic AMP. So each of those cyclic AMPs activates a protein kinase that can act on thousands of substrate molecules. So you can see it's kind of a domino effect here with the amplification. One molecule of epinephrine may result in the breakdown of millions of glycogen molecules into glucose, but it makes the system very efficient. So control of endocrine signals, they can be regulated by signals from the nervous system, as well as chemical changes going on in the blood or other hormones. Most hormonal regulation is going to operate with negative feedback. So it's going to detect a change and attempt to reverse it. That is most examples in the body. There are a few where you have positive feedback loops, such as labor, where you would increase the contractions. So the hypothalamus and pituitary gland are important centers of the control in the endocrine system. This is the major link between the nervous system and the endocrine system. This is how you can have something that's going on in your head with your mental and emotional world turn around and affect your physical body. The hypothalamus is going to do a lot of the regulation of the nervous and endocrine systems. It will secrete regulatory hormones that will control the anterior pituitary gland. The anterior pituitary gland is sometimes referred to as the master gland, but the hypothalamus is the master's master. So it will release hormones from the posterior pituitary gland as well. And then it can have direct neural control over some of the endocrine cells in your adrenal medulla. So the pituitary is going to be attached to the hypothalamus by an infundibulum. So you'll have the anterior and posterior pituitary. The anterior is sometimes referred to as the adenohypophysis, and the posterior is the neurohypophysis. So in here, neuro gives you the hint that that one is going to have much more nervous system control. So we've got a few pictures here that show this connection here, that you've got a difference with your anterior and posterior pituitary. So anterior pituitary hormones are going to be secreted by other anterior. There's going to have hormones that will control other endocrine organs. And then from the posterior, you can see where you've got this direct neural control link in here. The posterior is only going to release two hormones, ADH and oxytocin. So with the posterior, it's going to use a portal system, which is a very efficient way of having chemicals communicate. The hormones are going to go directly from the hypothalamus to the anterior pituitary, and it does this without dilution or circulating around the body first. So that's what a portal system does, is it's going to take blood flow directly from one location to another. Normally, blood flow is going to go to an organ and then back to the heart, and it diffuses throughout the body. By taking it from one organ to the second stop in there, it's going to make it more efficient. So the rate at which the hypothalamus secretes the regulatory hormones is usually going to be controlled through negative feedback. So the anterior pituitary, it releases a lot of hormones that are going to be stimulated by a releasing hormone that will come from the hypothalamus, and then you'll have an inhibiting hormone that will come from the hypothalamus that will shut it down. So a releasing hormone is going to stimulate synthesis. An inhibiting hormone is going to prevent synthesis. These will be regulated by negative feedback loops. So the hypothalamic hormones made by neurosecretory cells get transported by the hypophyseal portal system. So these anterior pituitary hormones that end up acting on another endocrine gland is called a tropic hormone. So when you see tropic hormone in the name, that's a hint to you that it's going to act on another endocrine gland. So the hormones we're looking at in here, we've got human growth hormone, or HGH, also called somatostatin. This one is going to go on to stimulate the secretion of the insulin-like growth factors, which will promote growth and protein synthesis. Thyroid stimulating hormone, or TSH, thyrotropin. This is going to stimulate the synthesis and secretion of the thyroid hormones from the thyroid gland. FSH, follicle stimulating hormone, another tropic hormone. This will trigger the ovaries to go through oocyte development, and then it will stimulate the testes to produce testosterone. Luteinizing hormone. This is going to also stimulate the ovaries. It will kick things up a notch and stimulate ovulation, With the testes, it's just going to kick up the testosterone production a bit. Prolactin, this is going to stimulate milk secretion in the mammary glands. ACTH, Adrenocorticotropin hormone. This is going to stimulate the glucocorticoid secretion by the adrenal cortex. So again, you can let the names help you out here. Gluco means it's going to affect glucose. Cortico means it's in the cortex of the adrenal gland. And then MSH, or melanocyte stimulating hormone. Its role isn't fully understood. It is related to stress because corticotropin releasing hormone, CRH, is going to stimulate it. And we'll talk about that one a little bit more later on, but it does stimulate melanocytes a bit. It just does it much more so in animals. So this is a nice diagram here that kind of summarizes the endocrine glands as well, and their regulation from the anterior and posterior pituitary. And then this is a similar gland that's going to show things where they come from the anterior and posterior pituitary and onto their target organs. So it's just a different way of pretty much giving the same information in this chart. So we'll look a little bit more closely at human growth hormone. The type of cell that's going to produce it is a somatotroph. And within the target cells, it's going to increase the secretion of the insulin-like growth factors that will either act locally or in the bloodstream. So they're going to act similar to insulin, but not entirely the same. Some of their target cells are the liver, skeletal muscle, cartilage, and bone. So it is going to promote cell growth and cell division. It will cause them to take up more of the amino acids and do more protein synthesis. So it will stimulate lipolysis in the adipose tissue so that the fatty acids can be broken down and used for ATP production. So that's where it is different from insulin. Insulin does not stimulate breaking down fat. The insulin-like growth factors that come from human growth hormone do. It will retard the use of glucose for ATP production so the blood glucose can remain relatively stable and high enough to supply the brain. So the brain does like to have its blood glucose stay constant, so that's a pretty important function in there. So this image here is going to show you some of the effects in here from growth hormone, where it goes to the liver, the insulin-like growth factors. So these are insulin-like effects. These are effects that are different than insulin. So that lets you see a side-by-side comparison. So when we look at regulating human growth hormone, low blood sugar will trigger the release of growth hormone releasing hormone from the hypothalamus. This in turn is going to cause the anterior pituitary to release more human growth hormone that will lead to more glycogen breakdown. This will happen to give you more glucose from the liver cells. When you have blood sugar that is high, it's going to release growth hormone inhibiting hormone from the hypothalamus. So you'll have less human growth hormone, and the glycogen does not break down. So if you're looking at how can you promote maximum growth, say you're doing strength training and you want to maximize muscle growth in there, then you don't want to follow that with a high glucose meal in there because that would raise up your blood sugar and then have growth hormone inhibiting hormone. So that's going to kind of counteract the effects of it. So what you eat after a workout like that will be important. Having a meal that has more protein in it would actually be more useful. It's not going to raise up the blood sugar to change growth hormone levels. And then it will also give you the building blocks for protein synthesis to build muscle. So this growth hormone, the levels of it are going to be higher when you're younger. They're going to pretty drastically decrease around age 30. And that accounts for a lot of the things that people feel when they get around age 30, where things just don't heal as fast anymore. Maintaining body weight, proper body weight, gets a little bit more challenging as well. So it may seem like, well, you'd really like to have a lot of this. You don't. You want a proper balance of it. Excess of it can raise the blood glucose concentration. And then the pancreas would constantly be releasing insulin and lead to beta cell burnout. So it can have a diabetogenic effect, causing diabetes mellitus if no insulin activity can occur eventually. So this is a nice comparison in there, looking at what growth hormone releasing hormone when you raise it, growth hormone inhibiting hormone when you shut things down. So TSH, thyroid stimulating hormone. The hypothalamus is going to regulate the thyrotroph cells. They are the ones that produce TSH, and that's going to stimulate the synthesis and secretion of the T3 and T4 hormones. The metabolic rate becomes stimulated through this. Follicle stimulating hormone. So this is going to control the gonads and the gonadotrophs. The gonadotrophs release the FSH, and it's going to initiate the formation of the follicles within the ovary. Those will secrete estrogen. In the male, it will stimulate sperm production in the testes. Luteinizing hormone. So the releasing hormones come from the hypothalamus, again, to stimulate the gonadotrophs. So troph means it's going to act on another organ, and it's going to act on the gonads. So in females, LH is going to increase the secretion of estrogen. You'll have ovulation of the secondary oocyte from the ovary, formation of the corpus luteum, and that corpus luteum will then secrete progesterone. In males, it's going to stimulate the interstitial cells to secrete testosterone. So hypogonadism is something that can result from inadequate levels of this. So we talk about those hormones more in the reproductive system. Prolactin. Here, the hypothalamus will regulate the lactotroph cells that produce the prolactin. So under the right conditions, the prolactin will cause milk production. So the suckling will reduce the levels of hypothalamic inhibition, and the prolactin levels then increase along with milk production. So when nursing stops, milk production will slow and eventually stop. So when we say under the right conditions, pregnancy does lead to the right conditions for this to happen. It isn't going to happen just randomly. ACTH, we have the hypothalamic releasing hormones that will control this again. They're going to stimulate the corticotrophs, which will secrete the ACTH and MSH. These will stimulate the adrenal cortex that produces the glucocorticoids. So it's going to affect blood glucose when you look at the name glucocorticoid. MSH also comes from those corticotroph cells. It's going to have an increase in skin pigmentation. So this has been better studied in other animals. So we see this particularly in frogs, but it does affect pigmentation a little bit in humans. It's not going to change your pigmentation enough that you would look like you are a different race. However, there is pigmentation changes that are more subtle that can occur because of this. So they say it's virtually non-functional. It's just very slight. So in the non-primate vertebrates, the pars intermedialis is going to release the MSH. So when you have local trauma to the skin, such as sun exposure, you'll actually produce some MSH, and that will cause more pigmentation as well. So with the posterior pituitary, it doesn't actually synthesize the hormones. What it's going to do is just store and release them. They're going to be made in the hypothalamus. So the hormones that we're going to have here are oxytocin and ADH, or antidiuretic hormone, which is sometimes called vasopressin. So malfunction of this hormone will lead to diabetes insipidus. So with oxytocin, you've got two target tissues that are going to both use the neuroendocrine reflexes. So during delivery, the baby's head is going to start to stretch the cervix, and the hormone release will enhance the uterine muscle contractions so that the baby and the placenta can be delivered. Then after delivery, with the suckling, as well as even hearing a baby's cry, will promote more milk ejection. So the hormone will cause the muscle contraction and milk ejection in there. So it also does play a role in fostering the bond between the mother and the baby. Antidiuretic hormone, this is going to decrease urine production. So a diuretic is a substance that causes more urine production. Antidiuretic is going to shut it down. It's trying to conserve water, so it's also going to decrease the amount of fluid lost in sweat, and it helps to increase the blood pressure. So when the blood volume is lower, you need to increase the pressure to maintain blood flow to the head. So looking at the thyroid gland a little bit more, here we can see some images of it. It's on the anterior side of the neck, kind of a butterfly-shaped gland. So it's located inferior to the larynx, and the two lobes of it are connected by the isthmus. So there's a little isthmus there. You've got the thyroid follicles that are going to produce thyroxine or tetraiodothyroxine. That one is commonly called T4, and T3 triiodothyroxine. So T4 has 4 iodines on it, T3 has 3 iodines on it. That's where the number names come from. These target every tissue and cell in the body, and they're going to help to increase the basal metabolic rate, protein synthesis, help increase use of glucose and fatty acids for ATP production. So getting ATP production and energy is critical with these. The parafollicular cells, or C cells, produce calcitonin. So calcitonin is going to target bone cells only. And what it does is it lowers the calcium in the bloodstream by inhibiting bone resorption. So it helps to keep the calcium in the bone. So here we can see pathways of thyroid hormone production, where you've got the thyroglobulin that's synthesized and discharged into the follicle lumen. You're going to trap and take in the iodine. It's going to be oxidized to the active form. The iodine will enter the follicle lumen. It gets attached to the tyrosine. And then your iodinated tyrosines are going to be linked together, and that's going to form your T3 and T4. The thyroglobulin colloid is going to be endocytosed, and then it will be combined within a lysosome. And then the lysosomal enzymes will cleave the T4 and the T3 from the thyroglobulin colloid, and the hormone can then diffuse from the follicle into the bloodstream. So you can see the hormone leaving there. So iodine is critical for the formation of thyroid hormone. So the actions of thyroid hormones, it's going to stimulate carbohydrate absorption from the small intestine and increase fatty acid release from the adipocytes. Both of these are used to get a higher metabolic rate and produce more energy. So the increased metabolic rate created by thyroid hormone is actually going to produce a significant portion of the heat that's generated by the body every day. So if somebody is hypothyroid, one of the things that is a very common symptom of that is they are often cold, as well as fatigue and just overall lack of energy compared to a normal state. So the permissive effects on the catecholamines, they will cause upregulation of the beta-adrenergic receptors in a lot of the tissues like the heart and nerves. It's important for growth and development, so you need it to produce growth hormone for proper nerve development. It can affect mental development during fetal life and lead to cretinism. So the most common form of cretinism around the world is actually iodine deficiency. That's pretty rare in the United States, but it does happen in other countries. So this is going to show here the negative feedback loop here. When you have low levels of T3 or T4, it will affect the thyrotropin releasing hormone. That's going to in turn affect TSH. TSH will lead to production of the thyroid hormones, and as those are elevated, it will work in the negative feedback loop to shut things down. So this table here just gives a few effects summarized of the thyroid hormones on the peripheral tissue. So controlling body temperature, heart rate, blood pressure, sensitivity to sympathetic stimulation. It can affect the respiratory centers, blood cell formation and oxygen delivery, sensitivity in other endocrine tissues, and then the turnover of minerals in bone. So some conditions that go with this: hypothyroidism. One cause of it is iodine deficiency, and what will happen is the gland is trying to make up for this deficiency, so it will become overstimulated and can develop a goiter. So it's primary when it's the thyroid gland. It's secondary if the issue is in the anterior pituitary. Tertiary if the issue is in the hypothalamus. So 95% of all cases are due to either damage or loss of function of the thyroid tissue or to iodine deficiency. So this picture here is showing a person with a very large goiter in their neck. Goiters are, in this country, are detected well before they get to that point. With Hashimoto's thyroiditis in there, this one is autoimmune. So the T cells attack and destroy thyroid cells. So you'll end up with elevation of the TSH levels, and there is the potential for a goiter to form with that. When someone does have hypothyroid, the signs and symptoms: fatigue, weight gain, cold intolerance, changes in the skin. They'll tend to more have dry skin and hair. Appetite and gastrointestinal function can be involved, and decreased concentration. So one of the more frustrating things for people a lot of times is the decreased concentration ability, where they will refer to it as kind of having brain fog with the thyroid. Hyperthyroidism or thyrotoxicosis, again, primary is when it's in the thyroid gland, secondary if it's the anterior pituitary, tertiary if it's in the hypothalamus. Here you've got too much of it. Some signs and symptoms include weight loss, heat intolerance, increased appetite, increased sympathetic or nervous activity, so they may be kind of jittery, anxious, have tremors, tachycardia, fast heart rate. This can also be an autoimmune disorder where the plasma antibodies will recognize and stimulate the TSH receptors, and then they end up overstimulating the thyroid cells. So with this, it can lead to kind of a bug-eyed appearance in there, the bulging eyes that is seen in this picture. So the C cells, these are located between the follicles, and they respond directly to the calcium levels in the body fluids. They're going to be the ones that release calcitonin to decrease the calcium concentrations in the body. So it will do this by inhibiting the osteoclasts. This will help slow down the release of the calcium from bone, keeping the calcium in the bone, and then it will stimulate calcium excretion by the kidneys. So the parathyroid, this is going to be for pea-sized glands that are usually embedded in the lobes of the thyroid gland. So you can see them here in this picture. Those are the principal cells that produce the hormone. The oxyphil cells, we don't really know what their function is yet. So parathyroid hormone will raise blood calcium levels. It's going to increase the osteoclast activity. So it starts to break down bone to reabsorb the calcium. In the kidney, it would promote formation of calcitriol that will increase absorption of calcium and magnesium in the intestinal tract. So it's got the opposite function of calcitonin. So the blood calcium levels are going to directly control both the calcitonin and PTH levels through negative feedback loops. So this here is going to show comparison of your thyroid and hypothyroid glands with their effects on the blood calcium levels. So PTH, you're going to break down calcium in the bone, absorb more of it. Calcitonin, you're going to keep the calcium in the bone and excrete more of it. So your adrenal glands, adrenal literally means next to the kidney. And they're not really next to it, they're on top of the kidney. But the adrenal glands have two functionally distinct regions, the adrenal cortex and the medulla. With the cortex, it's going to produce the mineralocorticoids. So it's going to affect mineral homeostasis. From mineral, cortico tells you it's in the cortex. Glucocorticoids affect glucose homeostasis. Your primary one there is cortisol. And then you have the androgens, which will have masculinizing effects. The dehydroepiandrosterone, DHEA, is more significant in females. The adrenal medulla, it's going to have some modified sympathetic ganglion from the autonomic nervous system in there, so it can help to intensify your sympathetic or fight or flight response. And it will produce epinephrine and norepinephrine in there. So here is a table that shows the different zones in the adrenal. In the adrenal cortex, it's going to synthesize and release those steroid hormones that are the corticosteroids. So you've got different corticosteroids produced in the different layers. The zona glomerulosa makes the mineralocorticoids. Aldosterone would be your primary one there. The zona fasciculata makes your glucocorticoids, so that would be cortisol. And then the zona reticularis makes your gonadotropins, which would be your androgens. So in here you can see the different zones in this picture as well. So mineralocorticoids, they're going to influence your electrolyte concentrations. Aldosterone's the most important one. It's going to help to maintain the sodium balance by reducing how much you excrete. It's going to cause the kidneys to reabsorb sodium. Where sodium goes, water follows. So the secretion is stimulated by rising blood levels of potassium and low sodium. It decreases the blood volume or blood pressure. This will end up affecting the renin-angiotensin aldosterone system. So the kidneys release renin, that gets converted into angiotensin 2, and that in turn will stimulate the aldosterone release. So the plasma concentration of the sodium and potassium directly will affect the zona glomerulosa cells. ACTH, it's going to cause a small increase of aldosterone during stress. And then the atrial natriuretic peptide will inhibit the activity of the zona glomerulosa. So that will actually shut down that and lower blood pressure a little bit. So this here again, you can see where you've got the anterior pituitary, you can have the stress come in, the stress response, and then that going to the cortex. You can see the role of blood pressure in here, how the atrial natriuretic peptide has an inhibitory effect. That one will actually lower the blood pressure. The effects of the sodium and potassium levels on here, its effect on the kidney, starting that renin, angiotensin, aldosterone system in there. So if you need more of a visual, that's a good diagram to look at. So glucocorticoids. These will secrete cortisol with corticosterone. The liver converts the cortisol to cortisone. This is going to help the body resist stress responses. It's not going to eliminate the stress. When we say resist stress, it's going to mean cope with it. It's going to help to keep the blood sugars relatively constant, maintain the blood volume, and prevent water from shifting into the tissue. So things that will happen, it's going to provoke gluconeogenesis. So that literally means generates new glucose. You'll have a rise in blood glucose, fatty acids, and amino acids. It does have an anti-inflammatory effect. It inhibits the activities of the white blood cells. So if you think about it, if you're in a fight or flight response and a stress response, having more inflammation and immune response is not going to help you be able to fight off the stress. And that's what the goal of this hormone is. So excessive levels of this, it can depress cartilage and bone formation, inhibit inflammation. When cortisone injections are used therapeutically, that's generally the goal, to inhibit the inflammation. It's not going to actually cause the tissue to heal, because it's going to actually stop the formation of the healing process in there. So they do need to be used with caution. It's going to depress the immune system, and then it will promote changes in the cardiovascular, neural, and gastrointestinal function. So when it affects metabolism, it's going to increase the rate of protein synthesis. It will help convert amino acids into glucose, so that you can get more energy. It's, again, the goal is try and give the body enough energy to be able to maintain the stress response. It will also stimulate lipolysis, so that will help you get some energy from fat. It will increase glucose synthesis for more ATP production. Again, it's wanting you to have the energy to be able to deal with the stress. It will raise the blood pressure by vasoconstriction, and then the anti-inflammatory effects. So those will reduce release of histamine from the mast cells, decrease capillary permeability, and decrease phagocytosis. So when this is used topically, it will reduce the effects of this area towards the skin. So gonadotropins, they're stimulated by ACTH to release the androgens. So most gonadotropins that are secreted are androgens. They're a male sex hormone. Most important one is testosterone. So androgens help contribute to the onset of puberty and the appearance of the secondary sex characteristics, and they'll influence sex drive in females. So excess androgens can be converted into estrogens after menopause, but the effect of androgens is really pretty minimal compared to testosterone. So their effects in males is a lot less than it is in females. Sometimes people think, well, I'd like to have a female with a lot of androgens in there for a lot of sex drive. Excess androgens don't generally result in excess sex drive. They'll end up in more masculinizing characteristics for the female, like more thicker skin, more coarse body hair, like a male. So they're generally not something that most females are interested in having. The adrenal medulla, this is going to have chromaffin cells that will secrete the epinephrine and norepinephrine. So the hormones are sympathomimetic. They're going to mimic the sympathetic nervous system. So it will trigger something similar to fight or flight behavior. The preganglionic neurons will secrete acetylcholine. These will actually be secreted in the morning a little bit. The secretion of these hormones will raise the blood glucose, cause blood vessels to constrict, the heart to beat faster. It's going to shift more blood to the brain, heart, and skeletal muscle. And the epinephrine is the most potent stimulator of the heart and the metabolic activities. So again, it's helping you deal with stress. Norepinephrine, on the other hand, is more influential on the peripheral vasoconstriction and blood pressure. So the pancreas, this is going to be found in the abdomen. It's going to be between the inferior border of the stomach and the proximal portion of the small intestine. It does have some exocrine cells, the acinar cells that are going to produce digestive enzymes. And then the endocrine portion is in the pancreatic islets. They're sometimes called the islets of Langerhans. You've got 5 types of cells in there. 20% of them are alpha cells. They're going to secrete glucagon. So the way I remember this, glucagon is saying the glucose is almost gone. It's going to raise the blood sugar. 70% are beta cells. They're going to secrete insulin. It lowers the blood sugar. It's going to help take the sugar out of the bloodstream and take it into the cells for the cells to be able to use it. The delta cells, or 5%, they secrete somatostatin that inhibits both the insulin and glucagon. And then the F cells secrete pancreatic polypeptide that will inhibit the somatostatin and decrease gallbladder secretions. G cells are going to cause an increase in the acid secretion and gastrin to increase gastric motility and stomach emptying. So your blood glucose levels are going to be the key things that affect this in here. Low blood glucose stimulates the release of glucagon. High blood glucose is going to stimulate the release of insulin. So this picture again here, this is a nice one for being able to compare insulin and glucagon next to each other, the different cells that they target. So you do have all of these notes available as a Word document, so you can enlarge any of these diagrams that you want as well. So diabetes mellitus is going to result from hyposecretion or hypoactivity of insulin. There's 3 signs that go with it: polyuria, polydipsia, and polyphagia. So lots of urine, lots of thirst, lots of hungry. So with hyperinsulinism, you're going to have excessive insulin secretion that will end up resulting in hypoglycemia. So this is a nice little table that shows the different organs involved in here. So you've got muscle, adipose, and liver tissue in here. Their responses to insulin deficiency. So what happens with hyperglycemia, the glycosiuria, so the polyuria that would go with that, you would have dehydration. Soft eyeballs, that's not something that most people are typically going to notice. Polydipsia, go with that. Your fatigue, weight loss, polyphagia. And then some things that can be noticed by other people is the acetone breath in there. So a lot of times somebody whose blood sugar is out of control, you can smell it on their breath. Nausea and vomiting, so it can affect with the respiratory system with hyperpnea. Can have cardiac irregularities, and then central nervous system depression. The big danger here is the coma, and if the blood sugar is not helped at that point, the coma can lead to death. So reproductive hormones in the males, these are going to occur in the testes. They're going to regulate the sperm production and development of the male sex organs, giving secondary sex characteristics. Inhibin is going to shut down FSH secretion. In the females, you've got the ovaries, and they're going to produce estrogen. So a couple forms of estradiol and estradiol and progesterone. These will affect the uterine and mammary gland development and function. It will affect the external genital structure and then give secondary sex characteristics and also help to control the menstrual cycle. Inhibin is going to shut down FSH secretion. So the inhibin is important in there. It keeps there from being too much sperm production in a male. In the female, this is why you're only going to ovulate one egg at a time, is FSH will shut that down. The uterus really is designed to accommodate one. Relaxin, it's going to increase the flexibility of the pubic symphysis, so this is going to be most prevalent at the end of pregnancy for helping to let the pelvis change shape a little bit in there and then accommodating passing the baby through the birth canal. The pineal gland, it's a small gland attached to the third ventricle of the brain. It's going to have pinealocytes and neuroglia. It's going to produce melatonin. This is going to help set your biological clock. You can get melatonin as a supplement. It's been helpful with jet lag and then SAD treatment, the seasonal affective disorder. What can also be really helpful for these people is bright light therapy. So the effectiveness of bright light therapy is actually really good. The studies are pretty amazing on it. So melatonin secretion will produce sleepiness. So this occurs during darkness because there is a lack of stimulation from the sympathetic ganglion. Light will strike the retina, and that stimulates the suprachiasmatic region of the hypothalamus. That stimulates the sympathetic ganglion and then the pineal gland. So with light, there is no melatonin production. With dark, it allows melatonin production. So it naturally makes you want to be sleepy at night. So this can also have a pretty big impact on other things in health. There's been a lot of interesting studies looking at people who work night shift, and their melatonin levels are out of whack with what their lifestyle is. The thymus, this is a lobulated gland that's deep to the sternum and the thorax, so it's going to be just anterior to the heart. It plays an important role in maturing the T cells. So the hormones come from this will lead to the proliferation and maturation of the T cells. It's biggest at puberty, and after that it's going to diminish as you get older. By the time you're age 50, it's down to about a quarter of its original size, so it gets pretty small in there. Hormones that come from this one: thymosin, thymic humoral factor, thymic factor, and thymopoietin. So other endocrine-like organs, the heart, it will secrete atrial natriuretic peptide. That actually lowers blood pressure in there. The skin initiates the synthesis of calcitriol for vitamin D. With the kidney, it secretes renin and erythropoietin. It's also going to be involved with that vitamin D production. It's one of the steps in there, as well as red blood cell synthesis. The liver secretes the erythropoietin angiotensinogen. This is going to aid with vitamin D production, as well as the insulin-like growth factors. The placenta will secrete human chorionic gonadotropin, HCG. That's actually the hormone that is tested for in a home pregnancy test. The stomach will secrete gastrin and cholecystokinin and other enteroendocrine hormones that will affect digestion. So the adipose tissue, it releases leptin. This is a satiety hormone, and it will also increase energy expenditure. So more leptin levels mean you feel satisfied and not as hungry. The eicosanoids, so leukotrienes and prostaglandins, are local hormones that are going to be released by all body cells, and they're released upon trauma. So they will promote inflammation. They also will increase allergic responses with the leukotrienes. They'll lead to smooth muscle contraction, glandular secretion, blood flow, platelet function, nerve transmission, and metabolism are all influenced by prostaglandins. So the stress response, this is going to involve several things in the endocrine system. So if you understand the stress response, you inherently have to understand a lot of other parts of the endocrine system. Stressors are the stimuli that will produce the general adaptation syndrome. They can include almost any disturbance, hot or cold, surgeries, poison, infection, fever, and definitely strong emotional responses that can do this. Stress is really any change, good or bad. It's just the bad ones tend to have longer effects, and so we notice those. It resets the body's need to meet an emergency. So some stress is actually good. Eustress is a productive stress that helps prepare us for certain challenges. So going to school is generally considered a eustress because it should result in something positive in your life in the end. You're going to have personal growth from it. Distress is going to be harmful. It's going to lower your resistance to infection. So this is a nice picture here that summarizes a lot of these things. So you can see what's going to come from the different hormones, what stimulates it. So you can follow the stress response at the top. Hypothalamus, the nerve initiated from the beginning. And then you've got the endocrine support that's going to come along from behind it, from the adrenal glands, the liver, the thyroid gland. So it's a really nice summary chart of what goes on in there. So with the alarm phase, this is your immediate response to stress. It's going to be directed by the autonomic nervous system. You're going to have an immediate response to try and mobilize glucose stores with your fight or flight. The dominant hormone involved here is epinephrine. So if the stress does not go away, then you move into the resistance phase, sometimes called lowered resistance phase. So this will happen within a few hours. Now the dominant hormones are the glucocorticoids. The energy demands are still high, but your glycogen reserves are nearly exhausted at this point. So you've got to start getting the energy from other sources. And that's what this is going to help do. So each of these pictures shows immediate effects with the alarm phase in here, mental alertness, energy used by the cells, mobilizing the glycogen and lipid stores, changing circulation, reducing digestion, increasing sweat, changes in the heart and respiratory system. When you move into the resistance phase, that's going to change things up a bit here. So you're still going to need to have some energy, but you're going to have growth hormone coming in. You're going to try and conserve glucose in there. You're going to have elevation of the blood glucose from the glucagon. You're going to try and conserve the salts, water loss in there, so it can actually end up affecting the hydration in there. So the kidney affecting the renin, angiotensin, aldosterone system. So during the exhaustion phase, here you're going to have the homeostatic regulation start to break down. Here, this is not a good phase for your body. It does not benefit anybody's health when you get into this phase here. You're going to have failure of one or more organ systems, and it can eventually end up being fatal. It does not improve the health status of anything. Mineral imbalance, so some conditions that you can see as a result, gastritis, ulcerative colitis, irritable bowel, peptic ulcers, hypertension, asthma, rheumatoid arthritis, migraines, anxiety, depression. None of those are a good thing for a person. So a person under stress is at greater risk of developing chronic disease and dying prematurely. So we can look at interleukin-1 involvement in there. There's a link between stress and immunity. It can be secreted by the macrophages, stimulates the secretion of the adrenocorticotropin hormone. It stimulates production of immune substances and the feedback control, since the immune substances suppress the formation of interleukin 1 is involved. So the stress response is definitely not beneficial to anyone's health. So that is the endocrine system.